The needs of GU cancer survivors. First of all, we have a lot of them. So there are about 15 million survivors. Survivors are going to increase. We heard that here actually tonight. And about 4 million male GU survivors make up part of that. Prostate cancer accounts for about 3 million alone. There's about another million all told from the other GU sites, and a couple 100,000 who are female actually, so kidney and bladder cancer. The age of these survivors is relatively elderly, so about 60% or so are 65 or older. I'm sure we all realize that just from the epidemiology of these diseases. And then about a third or so are in the 40 to 64-year-old age group. So this helps to define what we need to be thinking about in these patients. So because of the age then, there are comorbidities in this patient population, and that's very important to the survivorship efforts, again, to know what sort of diseases and problems we'll be dealing with. So these are mild, moderate, and severe comorbidities in prostate cancer patients, and then at the end there, in those with malignancies of the genitourinary system, you can see, and largely because of the epidemiology of these diseases, there are lots of comorbidities. So the Institute of Medicine took an interest in this in 2005, and as they often do, they gave us some recommendations, which are actually quite sound and logical, and that's that cancer survivorship should be seen as a distinct phase of cancer care, possibly even its own specialty, and we should provide comprehensive care summaries and follow-up plans that are clearly explained that go from the specialist to possibly primary care, or whoever's going to be doing this survivorship care, in a very organized and clear manner. And they also said that we should develop clinical practice guidelines that are evidence-based and improve quality of life, and that these should address not only routine follow-up, but the late effects. And so, you know, it's hard to argue with these. They're pretty basic. So following this, we at MD Anderson, as many others did start a survivorship program. And it's included all of the genitourinary disease sites, other disease sites as well, of course, but we're going to concentrate on this one. So those of us who deal with prostate cancer, and, you know, survivorship never seemed to be that big a problem in that patient group, as at least the more localized ones that I dealt with, we kind of shrugged and said, well, okay, let's give them a golf course and let's give them an ED clinic, and they're probably all going to be happy. But we went ahead and did a survey of patients, and actually the vast majority had one or more unmet needs. And the most common needs were sexual problems, which you might imagine, concern for recurrence, obviously. And then they also said the coordination of care. So the care at this point in their disease journey can tend to get a little bit disjunct. And so it's very important then to keep it all together and to help to keep it organized. So what happens in survivorship, or in a true survivorship clinic or program then, is that not only is there surveillance for return of the cancer, but there should be also screening for other malignancies, those which a general population would see and those which might be related to the first malignancy. So we also address risk reduction and cancer prevention by lifestyle changes. And of course, there are the late effects, and you have to have side effects management, and you have to have folks who are comfortable and knowledgeable in dealing with this. And then there's the psychosocial needs, which is more or less for patients depending on their disease and their age and their treatment, of course. And so what's the eligibility for a survivorship clinic? Generally, it's when we start to feel comfortable about the fact that the risk of recurrence isn't that high anymore. So most patients get to go into these clinics after about 2 to 5 years. They must be disease-free. The point here is just routine care and not really acute treatment. And then the transition should be arranged by the primary team who's cared for this patient all along. So what we do is we came up with this passport type idea where patients are actually evaluated by our survivorship team, and the passport defines the disease, the patient's comorbidities, the treatment they had, the status of the disease and how that's proven. The late effects are taken into account as to what should be monitored and treated. There is a full follow-up plan in terms of what testing should be done and how frequently. And then the prevention and lifestyle issues are addressed and outlined as well. And this is all done in a personalized fashion for each patient. And so then either our survivorship team carries this out, in our own clinics, or patients very often like to be transitioned closer to home to perhaps their primary care physician. So let's use prostate cancer first as an example. So there are algorithms about all of this, and I'm not going to belabor this and read through all of this, but just to say that the algorithms do contain the plan for the follow-up, how frequent should it be, what testing should be done for each cancer, of course. And then, very importantly, there's the monitoring of the late effects, which are different based on disease and treatment. So for prostate, of course, it's incontinence, erectile dysfunction, the bowel dysfunction, and then bone health and the other issues that, of course, go along with androgen deprivation therapy. So we also look at risk reduction and early detection, and this is basically the same for the general population. So colorectal cancer screening, diet and weight management, exercise is important, tobacco cessation, and then monitoring sun exposure and skin cancer. And then the psychosocial aspects, the distress, the concerns, the body image, and the social support. And I must say in prostate cancer, for the most part at least, I found is that this last category doesn't seem to be used quite as much or quite as critical in many of these patients as it is perhaps in some of the younger patients. So we all know then what happens in patients after we treat them for prostate cancer. So the first one says, well, my problem when I wake up at 7, it takes me over 30 minutes to pee. And his friend says, well, my problem when I wake up at 8, it takes me forever to poop. And the third guy says, every morning I pee like a racehorse at 7 and I poop like a goose at 8. My problem is I don't get up till 9. So as you can see here, it's not just about the cancer effects, but if patients survive, they get old. You either get old or you don't. And that has a whole other set of issues that you have to add to the effects of the cancer treatment. And so in prostate cancer then, the quality of life issues have been very well documented and by patient-reported outcomes. And I'll show you just one example of this. Mostly they all say the same thing, and that's that with regard to urinary function, that patients do a little bit better after radiotherapy. The higher numbers here are better. And that with bowel function, radiation does a little bit worse than surgery. Those are always the comparisons. And that in terms of sexual function, it improves after prostatectomy. It gets worse after radiation. They meet at 5 years, and then it's all downhill from there. So men age, women do too, but we don't tend to make a federal case out of it. So actually, we tend to keep it under wraps. So then with regard to treatment, for prostate cancer, these effects have been worked out pretty well as well. So we all know about incontinence and the treatments and stricture and obstructive phenomenon and irritative symptoms and hematuria. And we don't have to belabor this. I mean, there are treatments. They're not all perfect, but we basically know what can be done about it. For rectal problems too, this is mainly after radiation. It's mainly bleeding. If you give it a little tincture of time, most of them resolve pretty much on their own. You may need some topicals. You may need some oral agents. Some severe things happen as well, and those take more treatment, luckily, or it's good that they don't occur very often. And I will say that less is better. So radiated tissue does not like to be biopsied. And so patients can have colonoscopy, but no biopsies, please. We warn our patients about this because that's how you tend to get the strictures and the fistulas. So look but don't touch. So this is very important in follow-up care. And then, of course, there are the erectile dysfunction issues. There are the drugs. When those don't work, men pretty much don't like to bother about the others, but we have an ED clinic that tends to stay fairly busy from prostate cancer, as well as the other GU malignancies. I want to say just a word about fatigue. We're not going to go through this. It looks like an eye test. And it's said that or recommended that fatigue should be screened for, and that's probably important. Mostly patients will tell you about this because it bothers them a lot, not so much in prostate cancer, but in the other GU diseases. And there are, you know, fairly complex algorithms for treatment, and I think it's just because it's a complex science where the pathophysiology has not been worked out well. It tends to be fairly subjective. The more obvious things, are very treatable, like the anemias and the hypothyroidism, and if somebody's not sleeping. But very often it's just this conglomerate of symptoms and causes, and it's pretty hard to work through. But that's something that can be done very well in our survivorship clinic as well, professionals who have the time and who have the knowledge. So then with seminoma, even if patients are surveilled after orchiectomy, there are still issues such as infertility and hypogonadism, and these, of course, are very different from prostate cancer. And if they're treated even more for their germ cell tumor with radiation or chemotherapy in addition to orchiectomy, then there are more issues and potential problems which must be surveilled, such as cardiovascular disease, the metabolic syndrome, neurotoxicity, and renal insufficiency. And so you must know to watch out for all of these things. And then, of course, in this group, there can be psychosocial problems. This is that young age group, in general, and in mid-30s average age. So this can be distressing to them, especially, about the concerns and the fertility issues. And so there is impaired spermatogenesis in this group of patients, anywhere from 5% to 20%, and the graph is about when men had their first child after treatment for testicular cancers. And you can see here the top line is surveillance, so they tend to go on and have children pretty soon after that. But then if they're treated with radiation or chemotherapy, there can be a delay, and sometimes this can never happen. And so in this group too, there's been a lot of work done about second malignancies, second solid tumors, and what we know is that the risk is greatest for those who are diagnosed at the youngest age. But even if you look at that average age group, that 35-year-old group, you still see that there's significant risk. The top line is seminoma, after that other germ cell tumors, and then the bottom line is the general population. So if these men live 10 years after their malignancy, on average, there's about a 10% increased risk of a second solid tumor, and you see that keeps going up with age. So that's why it's important to continue to follow these patients, and again, in a continuum and with people who are knowledgeable about what to look for. So bladder cancer as well has its own set of latent effects, renal insufficiency. There are the ostomy and the incontinence issues, and also the sexual considerations because the prostate is removed as well. So some of the same things going on there. And then we're not going to go through all of these. These are the risk reduction and early detection interventions, but I just want to point out that you have to do screening for women in this group, such as breast cancer and mammograms, and that's a whole nother controversial issue, but you have to be aware of it at least. And then in the gynecologic realm, because women get this disease. Kidney cancer as well, renal insufficiency, and again, that tends to happen also, well, not tends to, it does happen in a female population, so you have to screen for all of those pertinent things. And penile cancer is a tough one. I mean, it's not very common, but there are the incontinence issues, the lymphedema can be debilitating, and then there are all the sexual function issues, and along with that, the psychosocial and the body image problems. So that tends to be a tough one, and those patients tend to need more support. So in summary then, cancer survivorship is a distinct phase of cancer care, should be treated as such. It's very important. I think we're all coming to realize that. We're all going to be seeing more and more survivors. Cancer survivors have unique needs. Algorithms have been developed for routine follow-up, but it's more than that. Medical and psychosocial care should be tailored specifically for the disease site, the treatment, and the late effects. And research should be conducted to better define the issues that affect these cancer survivors. And with more of them coming down the line, I think we're going to be seeing more research and more dedication in this realm. And I thank you for your kind attention. And I just wanted to mention that we must all be sensitive to these patients' needs, unlike perhaps what goes on in some departments. So thank you again.